Welcome to the learning series titled Learning Together, Emergency Shelters and Substance Use Facilities. Please note that this session is being recorded. We are pleased to offer French simultaneous interpretation for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your Zoom screen. If you need support at any time during this webinar, you can reach out to one of our producers using the chat feature. My name is Jessica Hodge, and as improvement lead on this program, I am so excited to be joining you as the host for today's huddle. I would like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, I acknowledge that I am hosting this webinar from Perth, Ontario, which is the traditional territory of the Anishinaabe, Huron-Wendat, and Haudenosaunee St. Lawrence Iroquois peoples. This territory is covered by the Upper Canada Treaties. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. At Healthcare Excellence Canada, we continue on our learning journey and commitment to support improvement with and for all people in Canada. Next slide, please. Healthcare Excellence Canada is an organization with a relentless focus on improving healthcare with and for everyone in Canada. Launched in March 2021 from the amalgamation of the Canadian Patient Safety Institute and the Canadian Foundation for Healthcare Improvement, Healthcare Excellence Canada has greater capacity to support partners to turn proven innovations into widespread and lasting improvement in patient safety in all the dimensions of healthcare excellence. We believe in the power of people and evidence and know that by connecting them, we can achieve the best healthcare in the world. HEC is an independent, not-for-profit charity funded primarily by Health Canada. We are pleased to share that this program is delivered in partnership with the Canadian Centre on Substance Use and Addiction and the BC Patient Safety and Quality Council. It's now my pleasure to introduce our speakers for today's event, Dr. Monty Ghosh and from the University of Alberta and Kim Ritchie from Grenfell Ministries. I will now turn it over to them to introduce themselves. Monty, over to you for a quick introduction.
Thanks. Hi, everyone. It's a pleasure to meet you all. My name is Monty Ghosh. I'm an addiction physician and internal medicine specialist at the University of Alberta and the University of Calgary. And I'm currently residing on Treaty 7 territory, the traditional territories of our Blackfoot, our Métis and Tsuut'ina populations. I'm going to hand it over to my partner in crime, Kim Ritchie.
Hey guys, how's it going? So my name is Kim Ritchie and I am from Hamilton, Ontario. I am the Executive Director of the National Overdose Response Service, a person with lived experience. And I would like to acknowledge that I am currently standing on the traditional territories of the Huron-Wendat, Haudenosaunee, Mississaugas, and Erie nations.
Thank you both for being here. I will now turn it over to you to do your presentation on the National Overdose Response Service.
Oh, perfect. Do I share my screen? Is that okay? Or
the slides are up, Monty. So if you wanted to go to the next slide, you can just say next slide and our producers will advance for you.
Sure. No, thank you so much. So yes, this is our presentation on what we call the National Overdose Response Service. It's a program that has been our heart and soul for the last, Kim, how long do you think it's been? It's been about almost a year and a half now, I think.
About a year and a half. Yeah. 9 months of brainstorming, and we launched on December 15th.
Yeah, so really grateful to be here. Next slide. So we've done a lot of acknowledgement, of course, already, but we want to really, again, hammer the point home that we are in the unceded and traditional territories of thousands of First Nations, Métis, and even Indigenous First Peoples here on Turtle Island. Next slide. So some background and context, almost 60% of overdoses that occur throughout our nation occur in people's own homes, occur with people who are using alone by themselves. This number varies from jurisdiction to jurisdiction. For example, in our last quarterly report in Alberta, in Calgary, it was about 50%, in Edmonton, it was about 70%. We see some rural communities can be as high as 90%. Next slide. This is some data from Alberta as well. We see that rural and suburban communities are by far the hardest hit with the opioid crisis. And supervised consumption sites, while they're very effective and are a crucial and essential part of services for people who are using substances, they're only effective in reducing mortality rates within a 500-meter radius around them. up to 1,000 meters around them. And so beyond that, they don't reduce mortality rates. And the big question that we asked ourselves is, how do we reach the population? How do we reach the 80 to 90% of substance users who live beyond those boundaries of a supervised consumption service? Next slide. So the good news is that opioid overdoses can be reversed by naloxone kits. This is an evidence-based treatment approach. And we do know that supervised consumption sets are also evidence-based. They can reduce mortality, but they do have some geographic limitations. Next slide. And with that is our Norris response service. I'm going to pass it over to Kim to talk about this part.
So our solution, guys, let me tell you about it. Okay, so I'm going to give just a quick brief background around this. So the states were already doing this, just like safe injection sites. This started out with people with lived experience and people active in drug using communities already saving each other. They were already doing it. So in the states, Never Use Alone was offering remote supervised consumption to folks via telephone and over video to their peers, to their comrades, to their colleagues. And then we replicated it. So we talked to them. We're like, how can we do this here? And here at Grenfell Ministries, we started out with the Ontario line. And then we met the folks at Brave who were doing a virtual app. So we're looking at different avenues to providing different services, right? For the folks that don't have access to internet, this was a viable option through the phone line. And some people, like we know substance use is an illness of disconnection and dislocation. And this allows us to build rapport and build community and really center those things into perspective. So it was really quite amazing. So we all came together and we're like, well, what can we do? We're like, well, let's do a national line. So here we are, and we're about a few months in, and we've received over 2,000 calls and 18 incidents of overdoses reversed at this time, along with providing comprehensive case management in the forms of referrals to different resources, with 71 volunteers and a complement of 15 staff currently. So here we are, and this was our solution, and so far it's working. It's working, and people are building connection, and they're being resuscitated, and their overdoses are being reversed. And more than anything, we are establishing community across Canada.
So just to add to what Kim is saying, I forgot to add the Alberta piece. We've been doing this as well for the last 4 years, of trying to get this up and rolling since 2017 as a phone line. Just an idea that came from a patient of mine. He was in Grand Prairie, using substances alone, and I asked him if he had an naloxone kit and if he was using by himself, and he said he kind of was and he kind of wasn't. And when I asked him some more questions, he said he was FaceTiming his buddy in Edmonton and that they're using together. And as always, the smartest ideas come from people who use substances themselves. And I probed him on it more, and he's like, well, we have each other's addresses, and we can easily dispatch EMS services to each other if one of us overdoses. And that is sort of the concept here. So the way the line works is that it's a 1-800 number. You call the number and you get dispatched through to an operator who will answer your phone call. They'll ask you for the first 2 initials of your first name, first initials of your last name, your date of birth. They'll ask you for your location. They'll ask you for your exact address, which they do not keep. And then we will be with you on the phone as you use your substance. And if at any point in time during that phone call you stop being responsive, we will dispatch EMS services to your location. So that's the gist of how the line works. Next slide. Sorry, Kim, go for this. I apologize. I think I just totally I apologize.
You're doing great. You're doing great. To elaborate a little bit more, because we are servicing folks who are engaging in illegal activity, we also co-create safety plans. Okay, so we know the geography of Canada is unique. So up in like Nunavut, it would take 15 minutes to get a paramedic to somebody via helicopter. If we look at Nova Scotia during the really bad snowstorms, there's no way an ambulance can get through in that weather condition. So we're like, okay, so how can we meet the unique needs of folks across our nation? What does that look like? So we also co-create safety plans. So if you have a neighbor with naloxone, we can take that number as well. So we contact and enact the safety plan or the community response plan, and then call 911 in those situations where the person wants this approach to be enveloped. So it works really well, and it gives people a lot of power and autonomy over their care, which is super important to us as a peer-led, peer-run initiative. So I hope that elaborates a little bit more. To go on further though, so we discovered that Canada does not have a unified 911 dispatch system. So it's very difficult for me to dispatch an ambulance if I were to call 911 right now. I couldn't get an ambulance to the rural areas of BC, for example, right? Or to some of the more remote locations in our Atlantic region. So this dispatch company called Northern 911 unified the system like 10 years ago. So they're like way ahead of the game already, which is super awesome. And we hired them. So we call Northern 911 and then they patch us through to the appropriate dispatcher in that location. So it's super handy and they have been integral to this process.
Slide. Do you want to keep going?
Sure. I love it. Okay. Things we tell our clients. We talk to EMS. We're like, well, what do you guys need from us when we, phone you? And they're like, well, first off, it would really help if the porch light was on. Number two, animals need to be put away. That's not something like a lot of us would think about. But if you got a little kitten or you got a puppy who doesn't like strangers, they may not respond too well to the paramedics showing up on site. So we really encourage folks to put their animals away when they're going to use. We ask people to keep their door unlocked, but as we all know, again, we're engaging in legal activity. Again, there's a lot of culture around substance use that makes a little iffy about keeping your door unlocked, to say the least. We really do encourage folks to hide their drugs and paraphernalia for two reasons. We understand that the drug overdose prevention, the Good Samaritan Drug Overdose Act is a real thing. However, law enforcement is law enforcement and things are going to happen. So we do encourage folks to hide their substances and their paraphernalia so that they have access to that once they're released from hospital in case so they don't have to experience withdrawal symptoms, right? So this is very, very important to us. And it's very interesting. So we've had incidences where we have been given the incorrect address because somebody was getting high in a new location. And we had to use some interesting methods like a number tracing to find the location to save the person's life. And it's worked so far. So it's pretty wild and it's pretty amazing.
Next slide. Want to keep going, Kim? Sorry.
You don't have to apologize. Okay, our mission statement: to keep those who are using substances safe from overdose while upholding the people who use substances users' rights to dignity, respect, and confidentiality while providing access to supportive resources. Primary objectives: create and facilitate a national overdose response service to support all Canadians and Indigenous community members that use substances alone. This service will support to people as they use substances alone to mitigate the risk of overdose fatalities, provide a stigma-free space for people to use substances, dispatch emergency responses to support in the event of overdose when required, reduce the impact of the opiate crisis on people who use alone, provide linkage to additional care services and resources as required by those accessing service. Now, this is kind of the neat part. Half the people who volunteer on our line are active users in their substance using communities, and we really, really encourage that. We want people who use drugs actively participating and involved in our project. We cannot say how much that means to us and how much is the primary focus within the work we do.
Next slide. So some barriers. Oh, you can clearly tell we haven't rehearsed this. No, but some of the barriers that the service removes, it removes that geographic barrier that for folks to reach supervised consumption services. Especially during COVID, we knew this was true, right? We knew that a lot of the sites were at 50% capacity. A lot of people were told to physically distance. A lot of people were using in isolation because they might have had COVID and they were told to isolate. So this service really removes that geographic distance and that barrier. It takes away some other aspects as well. It takes away some of the stigma and fear of being seen. We've heard this from some of my clients who've said they do not want to go to supervised consumption sites because they don't want their employer, for example, to know. We also know this removes some of the time barrier issues. So in Edmonton, for example, not all the services are open 24/7 for supervised consumption sites. And so this provides an additional resource for them outside of those time periods. Next slide. So some of our target populations include those who use substances alone. Of course, English and French speaking individuals, and we do have a French-speaking line now that maybe Kim can elaborate on in just a second. We are targeting urban, suburban, rural communities, blue-collar workers, and of course, Indigenous communities. But there's others who might benefit from this indirectly as well. So as a frontline worker myself, as a service provider, it's often heartbreaking for me to send my patients away with just an naloxone kit and telling them to go supervised consumption, even though they live miles away from a supervised consumption service. And for that reason, this is an additional resource. It makes me feel better that there's something that I've done for them to use, to help them use alone so they don't overdose. It can help community-based agencies and support individuals who use substances from those agencies, and also those who have families who are trying to be supportive of individuals who are using substances. Kim, do you want to elaborate on the French-speaking line a bit?
Absolutely. So as part of our work with trying to service all of Canada, we developed a French component to our line. So we have 3 bilingual peers who are fluent in both French and English who can provide services to those who call who are Francophone. And it's quite amazing. We have a band app that allows it a whole virtual staff room. Everything we do is provided in both languages. Our goal in the future, though, is to expand to other languages, including Indigenous ones.
Next slide. So yeah, our services provided across all 10 provinces and 3 territories in Canada. So no matter where you are in this country, you can access our service. Next slide. So some of the studies that have been done include one study that was done by Jane Buxton, a colleague of mine in Vancouver. Some of you might have heard of her. So she did a study in which she found, or they surveyed 30 individuals who were using supervised consumption sites. They found that 68% of individuals who were using there had a personal cell phone or landline and were willing to use supervised consumption services. 43% of them preferred to use alone, and 80% of them reported using alone in the last 7 days. And then 20% of them said they felt safer using alone than with others. All very significant in terms of how this impacts our service and why we're doing what we're doing. And then 53% report that convenience was a significant reason as to why they were using alone. And since we launched, and Kim has the more updated numbers, I think we've had almost over 2,000 phone calls altogether. I think you said 20 overdoses, many of them which have been responded to, or at least overdose responses, I should say, and have had ambulances dispatched for resuscitation. And we've had 0 reported deaths.
Because they all call back. That's how it's well.
I mean, and that's the thing, right? From an idea, this actually works, is what we're learning, and just fantastic. Next slide. Do you want to go over this slide, Kim?
Absolutely. Our organization operates from a trauma-informed framework. Yes, we do. Our phone line operators are well-versed in mental health first aid and trauma-informed care, mindfulness training. What we provide our operators. Now, this is super important. This is super, super important, and I really want you guys to dig into this, okay? So we are a peer-run, peer-led agency, right? So it's very important that we cultivate a work culture that really promotes the mental health and well-being of those who work for us. So what we do is we pay a living wage. We offer people flexible shifts between 4 hours, 8 hours, and 12 hours. We provide endless professional development. And I mean endless. Every week, lunch and learns how to do different things across the board. And we provide that for free to the people who work with us, to our callers. We create virtual chat rooms that allow us to support callers. And those who call our line also work for us. And those who call our line also volunteer for us. So we are trying to eradicate the hierarchies that exist in social services, right? We don't want that. We don't want that. There's a lot of toxicity that comes with professionalism that we need to eradicate if we are going to provide a comprehensive service that complements and endorses a work environment that can really help people. So it's quite amazing that our employees are actively using substances, are able to come tell us that, have employment that gives a monetary gain that allows them to remain housed while they're using their trauma and creating meaning making out of their trauma to help other people. It is quite beautiful to see, to be frank. And the virtual staff room we created has took on a life of its own. It's took on a life of its own because we're all across Canada, all our volunteers, all our staff. And in that, especially during COVID, it reduced isolation, the memes, the camaraderie, the cohesion, the support that I've seen on there has been out of this world. And it's like beyond, it's become greater than the sum of its parts. I don't know even how else to say it. It's quite amazing. But yeah, so this is what we do. We care. We really, really care about our employees. We really, really care about our volunteers. We provide instant debriefing. You don't have to wait for an EPA when you work with us. We have access instantaneously to benefits, to mental health supports, to learning how to navigate your own trauma, your own stuff. And it's quite, I don't even know what to say. If you guys saw it, you'd be like, wow, what is that? But yeah, it's a thing. Anyways, I digress.
Next slide. So key pieces to our program is that we do work with Northern 911, as Kim mentioned earlier, to have dispatch services all across the country. We do have some liability protection. We have looked quite closely to the Federal Good Samaritan Act, and we have ways to navigate around it. But the secret sauce, as Kim has highlighted already, is that it is a peer run and peer driven. That is the secret sauce of Norris. And that's what keeps us going. And that's what keeps the program so patient centric compared to other programs that I've worked with. Next slide. So from an evaluation perspective, we're really looking at a quality improvement angle towards this. So we're looking at impacts to providers, college experiences and their family experiences as well. Their families' experiences as well. We're looking at improving the outcomes for people who are using substances alone, including reducing mortality rates because of the opioid crisis. We're looking to make sure that this is financially healthy as an intervention, and that this is at equal cost compared to physical supervised consumption services. And also, we're trying to improve provider experiences to ensure that providers do have options out there when they're working with clients who are using substances alone. Next slide. We collected very brief information. I've already kind of spoken about this. Next slide. The way we want you guys to use the service is that we want you guys to provide this number, much like an naloxone kit, to anybody who's using alone. Tell them about the service, tell them how to use it, and encourage them not to use alone where at all possible. Next slide. Any program can provide the service, including shelters, in which we're going to highlight in just a bit. Next slide. And anybody can provide this number, whether you're a pharmacist, physician, police officer, nurse, paramedic, community support worker, whoever you are, you can provide this resource to your patients, your clients. Next slide. There's a few key limitations for our service. One of them is that individuals may be drowsy and auto-overdosing, and as such, we might have to dispatch emergency services to them if they don't respond to our prompts. For some jurisdictions, police may come to the callouts, and so if we are going to be calling Northern 911 for dispatch services, we have to let them know that this might be a consequence. The Good Samaritan Act does not protect people who have warrants for their arrest or if they have children on site. Kim already spoke about paraphernalia being confiscated as well as substances. And then some people can overdose quite quickly, and our service is not foolproof. It's not an absolute solution to the problem, and it is a limitation. And we know that there will come a time when we haven't responded in time for an overdose, and that can be an issue. Next slide. What we do well is we provide support for our volunteers and staff. We connect with the community, provide continuous education on substance use, and provide professional development. We see the bigger picture in each unique individual. Next slide. I see we don't have as much time left right now, so we're just going to skip over all of these, actually, if that's okay. So next slide, next slide. We do have an evaluation framework in place. We won't go into any details on that. Next slide. And we are looking for volunteers. So if you've got anybody who you know who wants to volunteer for a service, please tell them to go to www.norris.ca, and we're happy to provide support. We can just end this PowerPoint right now, but what we want to state is that both Kim and myself work within the shelter system, and we're quite closely in tune with what goes on in the shelters. And we've noticed a few unique phenomena with the Norris Line. We have seen that people from shelters have been using it, even though they're not, they're not technically housed. We have people who are in supportive housing facilities who've been using the service quite regularly. We've also had people who are in isolation facilities. I've helped with a few of the task forces in Alberta to create the isolation facilities throughout our province. And we've had numerous individuals within these isolation facilities who have access to a phone, who have called the line to ask for support, and we've created safety plans with them to call people on site, staff on site, to help resuscitate them if there was an issue. And we would love to learn from you guys, the audience here, how you feel that this could work with sheltered populations, not just those in supportive housing and those in isolation facilities, but those who are rough sleeping as well, but also using the shelters. And happy to open it up to the floor.
Great. Thank you, Monty and Kim, for your presentation. We have a couple of minutes. We'll see if some questions come in from the audience. If you're comfortable, if you could leave a contact information where our participants could ask further questions or provide some feedback, like you said, about how this could work in a shelter format or setting. So we'll give a couple of moments, see if some questions come in. I did receive one question earlier. Can you tell us more about the safety plans you mentioned? And do the safety plans stay on file for individuals from one call to the next, or do you create a safety plan each time?
We have to create a safety plan each time, because here's the thing, right? There's Again, the people we serve are engaging in illegal acts, and we don't keep private information. We don't keep phone numbers, and we do not keep addresses. These are things that we don't do, just in case our records ever get subpoenaed for whatever reason, and because we are working with folks, again, in the substance use culture. So every time somebody calls, we have to create a safety plan, even a fresh one. Now, with that being said, we do work with people who are banned from other lines across Canada, because we service everyone. So with folks who have high acuity and complex needs, we often create caller protocols for our volunteers and staff to navigate those needs. And these protocols are co-created with the caller themselves. These are not something we implement behind their backs or on our own in a staff meeting. This is something that we do with them to best meet their needs while mitigating the challenges of running a line. Because some folks will call us like 20 times a day. And that's cool, just to tell us about their day, right? Oh yeah, Kimmy, I made it to probation today. Oh, that's great. And we really love those connections, but we also have to be mindful of that piece too, right? But it's super sweet. I love it.
Great, thank you. So I don't see any other questions coming in through the chat box, but thank you so much for putting your contact info in there. If anybody has further questions after the huddle, you can reach out, and we'll also include the slides in our follow-up email that goes out once a month. So anything that was skipped over, you'll also have that information.
Awesome, thank you.
And so thank you so much, Kim and Monty, for your presentation today. And we'll just launch some polls now. So please take time to finish the feedback polls on your screen. So our first question is, I'm just waiting for them to be pulled up. There we go. I know more about the National Overdose Response Service than I did prior to attending the huddle, from strongly agree, agree, neutral, disagree, strongly disagree. Overall, I was satisfied with my huddle experience, strongly agree, agree, neutral, disagree. And I will be able to apply what I learned from this huddle in my work, strongly agree to, again, strongly disagree. Please click submit to share your poll answers with us. And thanks again, everyone. Our next huddle and event, our next webinar will be on August 24th, and our next huddle will be on September 9th. So we look forward to seeing you then. And thanks again, Monty and Kim, for being here today.
Thank you. And I just want to say that, we're grateful to be here. We're willing to collaborate with any of you guys. So if you guys want to collaborate on something, just reach out to Kim and myself. It's all about connectivity within community, right? And the more we're connected with each of you in your communities, the better we can serve our patients and our clients. I keep saying patients because
you're a doctor.
But it's really our clients, right? And we're all in this together. So again, feel free to reach out. We're looking to learn more off of each other. Thank you.
Honestly, yeah, man, come hang out with us.
Yeah.
Great. Thank you. Have a good rest of your day.
See you guys.
Peace.